Good morning, everyone. Thanks for joining us. We'll go ahead and get started. This morning, we're very fortunate to have Dr. Jacob Walker give us update on dementia evaluation and treatment. Dr. Walker attended college at Indiana University, medical school at Boston University, and then did residency here at the University of Colorado, followed by a fellowship in geriatrics at the University of Chicago. Dr. Walker is a geriatrician and HIV specialist here at the University of Colorado and practices both specialties across a variety of clinical settings. His primary academic interest is the integration of geriatrics into the care of older adults living with HIV, with a particular focus in dementia care and dementia workforce enhancement. Dr. Walker will pause periodically for questions as we go. So audience members, I'll walk around with the microphone if you raise your hand. And for those attending via Zoom, please go ahead, type those questions into the chat as you think of them. And with that, Dr. Walker.
Thank you for the introduction. So, um, this is an updates talk. I'm here to talk about anything new in the world of dementia evaluation and treatment over the last few years. Most of you have seen many patients with dementia throughout your careers. We're not going to be reinventing the wheel here. I want just to make sure that we can provide the best counseling to our patients as we see new folks in clinic. I have no relevant financial disclosures. An important disclosure is that I am a new parent with a very cute baby at home who just started daycare. So if you hear what sounds like a Dickensian child coughing just off mic, that is me spreading disease. And if you hear features of dementia like apraxia, word substitution, or sentences trailing off, it's because I haven't gotten a lot of sleep this week. What I want is for all of us to be able to comfortably manage the in-office assessment of Alzheimer's disease and other dementias, to understand considerations in neuroimaging for dementia assessment, which may be new to some of us, and then counsel patients in the latest treatment options for dementia, including what you might have heard about in the news, which is monoclonal antibody therapies. Another important disclosure is that I am a geriatrician. I am not a neurologist, so you're getting the perspective of someone who's a primary care physician who sees a lot of dementia. You might get a very different version of this talk if you were attending neurology grand rounds. So just keep that in mind as we go. We always like to start with a case. So the person I want you to be thinking of, that I'm sure you have all encountered at some point, as we talked through updates, is the patient is presenting to your outpatient clinic with new cognitive concerns. Often there's a child or their family member or proxy who is noticing things like misplaced objects, forgetting conversations, reliance on to-do lists, getting lost while driving, missed appointments, errors in medications. And I want you to think about this person as someone who has minimal medical history, not on a lot of meds, and is still somewhat independent, but we're starting to worry about that slipping. The patient I'm thinking of, one of mine in seniors clinic, is actually a retired math professor who, no matter how many times I try to do cognitive testing on her, scores pretty darn well. She got a MOCA of 25 out of 30 just a couple months ago. Keep similar patients in your head as we move forward. To make sure we're all on the same page about dementia, I want to do a rapid review of terminology. First is dementia versus mild cognitive impairment. If we're going by the DSM-5, dementia is cognitive decline paired with functional decline. You may also hear the term major neurocognitive disorder used. That's our umbrella term for the many different pathophysiologies of dementia. But anytime someone is having a progressive cognitive decline that is impacting their day-to-day function, that's our dementia umbrella. When someone has cognitive decline, whether measurable or subjective, that is not impairing their day-to-day function, we lump that under MCI, or mild cognitive impairment. About 10% of cases of MCI will go on to develop functional impairment per year. It's not to say that all patients will go on to develop dementia, but we often think of MCI as sort of a precursor state to developing a neurodegenerative disease. And why does this matter? Dementia remains a top 5 cause of death among older US adults. It is often thought to be under-captured in our death reporting, as it often does not end up on death certificates. Despite a lot of fears about the increased number of cases of dementia, the increased need for geriatric workforce, the increased reliance on nursing homes as our population ages, the age-adjusted incidence and prevalence of dementia is actually going down. This is probably mostly driven by improvements in our preventive cardiovascular disease care, so controlling hypertension, controlling diabetes. So if we adjust for age, we're actually doing a pretty good job at preventing dementia. But because of growth in the US population, the number of cases per year in the US is rising and is expected to rise through about 2060. Alzheimer's disease is our most common type of dementia under that umbrella. You'll hear me use dementia and Alzheimer's disease somewhat interchangeably in this talk because that's where most of our treatments are focused. That is followed closely by vascular dementia, with many cases having mixed pathology on autopsy. And then I will not spend as much time talking about Lewy body dementia and frontotemporal dementia, which make up roughly 15 to 30% of cases of dementia, depending on the cohort. Most of this is going to be focused on Alzheimer's disease. When we are evaluating Alzheimer's disease, for our example patient in the clinic, as we teach most of our learners, history comes first. You're going to get most of your diagnostic clarity from the history alone. Typically, that is going to be gradual progression of cognitive impairment over time, usually with symptoms being detected by caregivers before they are reported by the patient. We also do a very good neuro exam, and we do all of our common cognitive tests, including the MoCA, the MMSE, or the SLUMS, as well as basic laboratory workup. These are all just things I want to make sure that you have done on your theoretical 81-year-old with memory loss that I'm sure you're all on top of. Guidelines differ on whether HIV and syphilis screening are necessary in dementia care. I am biased as an HIV provider. I'm going to get them on pretty much every patient because I can act upon them both. In-office testing that most of us are less familiar with and don't order a lot of. One is CSF testing. So we can actually detect the presence of amyloid plaques and abnormal tau proteins, chief pathologic features of Alzheimer's disease, in the CSF. They correlate well with so the CSF findings correlate well with what we see later on autopsy in the brain. And can be predictive of the development of cognitive decline down the road in someone with mild cognitive impairment. I'm not going to get into CSF testing too much today because it's usually not something we're going to put our patients through. It's typically not necessary. I've yet to have a patient, if I'm at all remotely interested in CSF testing, I've yet to have a patient say, yeah, let's do that lumbar puncture. So it doesn't come up a lot, but you will sometimes see neurology doing lumbar puncture to try to nail down a diagnosis of Alzheimer's disease. That'll be more relevant later when I get into treatment options. Don't forget that genetic testing is also available. Also not something we're going to send most of our patients for, but if you have someone with a family history of very early onset Alzheimer's disease, someone in their 50s or 60s and a first-degree relative, or many, many relatives with Alzheimer's disease, it is reasonable to send them for genetic testing. Qualitative studies suggest that patients do not experience any more distress, depression, anxiety, or feelings of hopelessness from knowing their genetic status. I think most of us would have, our knee-jerk response is, oh, I don't know that you want to know that you have this disease we can't do a lot about. Patients don't actually feel that way. They feel a little bit more empowered knowing if they carry a risk for Alzheimer's disease, they can then plan ahead. And then I'll talk more on the next slide, but in kind of newer area and what I expect might change in our practice a lot in the next 5 to 10 years is use of serum and plasma biomarkers for pathologic changes of Alzheimer's disease. The short version is there are many candidates and no conclusive uses. Serum biomarkers, especially the three on the right, a low amyloid beta 42/40 ratio, high phosphorylated tau 181, and high phosphorylated tau 217. All three of these have a high correlation with pathologic changes in the CSF. And pathologic changes on amyloid PET, which I'll get into in a minute. These are all commercially available. None that I know of are covered by any insurance. I've never ordered one. And right now, there's just no established role in clinical practice because we are still basing most of our diagnosis of Alzheimer's disease on cognitive testing, history, exam, and neuroimaging, which we'll talk about more. However, as we move into what may be a new era of targeted testing focused on amyloid levels or phosphorylated tau levels in the brain, this may become more and more important for our clinical decision making. So just know that these tests are out there. They correlate well with what we actually see going on in the brain. We don't really have a clear role for them now, and they're just not covered by most insurers or even readily available. I'm not sure you can order p-tau, either of the p-tau tests through our system. I'm pretty sure you can order the amyloid beta um, that's sent to one of our neurology labs. Someone correct me if I'm wrong on that one. And then the one bit of workup or testing that we are not going to be doing in the office, but don't forget is sort of our gold standard for dementia diagnosis is our neuropsych testing. This is 3 to 4 hours of intensive testing. Not all patients can sit through it, but it can give you a lot of valuable information about the type of dementia. It can also give patients a lot of valuable information about their strengths and weaknesses and how families can adjust. Neuropsych testing here is done out of neurosurgery, and our psychologists will sit down with patients afterwards to review the results and provide guidance. So it's a little bit of a diagnostic and therapeutic intervention. Because it is so time intensive and costly, with a very long wait time, I will usually save it for our atypical presentation, so someone with a very strange dementia phenotype, someone with overlapping psychiatric disease where you're trying to tease out depression or bipolar disorder versus a neurodegenerative disease. And then people like the theoretical math professor who have MCI from early dementia, but maybe scoring great on your in-office testing like your MOCA or MMSE. Neuropsych testing can help you tease out really subtle deficits that you might not be able to get on those 10, 15-minute tests. The only update in the world of neuropsych testing is that since COVID, there are multiple studies validating delivery via telehealth. That is something you can request from our neuropsych team. If you have a patient that, say, lives way up in the mountains or is homebound for some reason, they can do most of the testing via telehealth. For context, in the geriatrics clinic where we have a lot of dementia, we're probably sending around 20 to 30% of our patients for neuropsych testing at some point in their diagnostic workup. So it's not something we need for everyone, but can be very helpful for these unique cases. All right. That's most of your office-based testing. I'm going to cut into updates in the world of neuroimaging. As a quick review, most of us already practice this way, but this is how I frame the various conflicting guidelines from geriatrics and neurology groups. Most people are going to recommend pretty clearly that if someone has acute or rapid neurologic changes or atypical disease features, you want to get some form of structural neuroimaging, CT or MRI. There is some debate about whether that needs to be part of the initial evaluation of someone with dementia. I lean towards the recommendation for most neurology groups, which is that if someone has new memory changes or new memory complaints, I think it is valuable to have structural neuroimaging at some point since symptom onset. So if they've already gotten a CT head since these memory complaints started, that's kind of good enough in my book. What I counsel patients on is that I am not making a diagnosis of dementia based on your CT or your MRI. What I am looking for is unusual causes of cognitive changes that I don't want to otherwise miss. And I counsel them that even in more advanced Alzheimer's disease, their MRI might look fairly normal. I'm looking for things like a missed stroke, areas of encephalomalacia, tumors, neurocysticercosis, NPH, all things I've seen when I send people for that first MRI or CT. So we're ruling out weird causes. That's usually very reassuring to patients. I think it helps sort of ease their anxiety around getting that neuroimaging. MRI is preferred just because you're going to get more detail about brain structures and degree of vascular burden. But I'm usually not going to send someone for an MRI if I already have a CT, or if they can't tolerate MRI, CT I think is good enough for ruling out those unusual causes. There's a less certain role for advanced neuroimaging, which I'm going to get into in the next slide. But our options out there that we'll talk through are FDG PET, amyloid PET, tau PET, and the DAT scan. The one thing all groups can agree on is that serial imaging is not helpful in the workup of dementia. Someone already has Alzheimer's disease or vascular dementia, and you see changes over time, you're not going to get any good new diagnostic yield or make changes to their therapy based on serial imaging. So we don't need to be getting an MRI every couple of years in our Alzheimer's patients. It's not going to change what we do. All right, so those advanced neuroimaging options are, I really love this image from this group. I use it a lot. On the far left, we have the more typically used clinical MRI, which can show us atrophy in the hippocampus, atrophy in the temporal lobes. In FTD, we might see more atrophy in the frontal lobes. So it gives us a good idea of what's going on. Again, mostly using that to rule out unusual causes. Next to that, we have our FDG PET. If you guys are like me, we don't order a lot of pets in primary care. We're looking at glucose metabolism in the brain. In a healthy brain, you see at the top, you should kind of see pretty even distribution of glucose metabolism. The whole brain lights up. We're using a lot of glucose all the time in every part of the brain. In Alzheimer's disease, we see far less glucose metabolism in the temporal lobes, hippocampus, and frontal lobe. FDG PET is especially useful if you are struggling to differentiate Alzheimer's disease from frontotemporal dementia, where you'll see a really sharp drop in glucose metabolism in the frontal lobe specifically. So that's really the primary situation in which I will use FDG PET. I've only ordered a couple of these ever, but it's helpful for differentiating between our common types of dementia. Next to the right, we have our amyloid beta PET and tau PET. Again, these are looking at the presence of pathologic features of Alzheimer's disease in the brain. In a healthy brain, we should not see any amyloid plaques. We should not see any tau tangles, so nothing really lights up. In someone with Alzheimer's disease, we will see diffuse distribution of amyloid plaques concentrated in the temporal lobe and the frontal lobe. Not everyone with amyloid in the brain has Alzheimer's disease or is guaranteed to develop Alzheimer's disease, but everyone with Alzheimer's disease has amyloid in the brain. So this is sort of a rule out, I suppose. This becomes more relevant again when we get to some of our newer treatment options, but it's not something I've ever ordered. Like it's just not that useful unless you really need to know if someone has amyloid plaques when you're making a treatment decision. Basically same story for your tau PET. This is less available. I don't actually know that we can do it here. And the two on the right I've never even heard of. I'm not going to get into. But again, we're using these imaging modalities, these PET scans, to determine what pathologic changes have happened in the person's brain. And that only matters if we are making treatment decisions based on those pathologic changes. We'll get to later. Just as an example of the utility of these scans, so if you take patients presenting to a outpatient dementia center for sort of second opinions or reevaluation, amyloid beta PET led to changes in diagnosis and management in about 60% of uncertain cases, with no evidence in change of clinical outcomes. Tau PET, being newer and less available, led to changes in diagnosis in about 7.5% of patients and med management in about 5%. The caveat for both of these studies is that these are occurring in patients who'd already undergone a pretty extensive workup and were presenting for second opinion in a neurology clinic. But they may achieve greater clinical importance with targeted treatments. So can be helpful in the very uncertain cases. All right. I'm going to pause here for any questions in the workup before I get to updates and treatment, which is the bulk of this talk.
We do have a question in the chat from Eleanor. You talked about coverage for some of the serum biomarkers or lack thereof coverage, but Eleanor was wondering about insurance coverage for genetic testing.
Spotty, but does exist. So if you can justify it usually by stating that someone has a first-degree relative with early onset, I have had insurers cover it. My practice is that I'm usually sending someone to our neurogenetic counselors first, who can then help me navigate whether or not the testing they do is going to be covered, which is a bit of a cop-out answer. But coverage does exist for that genetic testing, similar with cancer screening. Other questions? All right. So brief review of what we've got out there for treatment. Not a lot, and pretty much all of it is most studied in Alzheimer's disease. So that's what I'm going to be focusing on. Remember, we've got out there on the market our acetylcholinesterase inhibitors and memantine for the treatment of Alzheimer's disease. Our acetylcholinesterase inhibitors are more commonly used. This is our donepezil, galantamine, and rivastigmine. What I teach learners, so that I don't sound like the most negative person in the world, is that these are imperfect drugs with real but modest effects, appropriate in select patients. If I give someone an acetylcholinesterase inhibitor versus a placebo and I track them over a year, they're going to score like 2 to 3 points different on a 70-point ADAS-Cog, which is like a super MoCA. Statistically significant, clinically not that significant, and most geriatricians try to shy away from these drugs, but it is a real effect that plays out in meta-analyses. So I will still use acetylcholinesterase inhibitors and memantine in folks who really want to do everything they can to slow cognitive decline, who aren't already on a lot of other medications, who don't have a lot of other comorbidities to focus on, and where I'm not worried about our side effects, especially with the acetylcholinesterase inhibitors. We see a lot of GI upset, weight loss, and bradycardia, things that might already be present in many of our patients with Alzheimer's disease. The caveat is there are a few studies out there suggesting that acetylcholinesterase inhibitors and memantine can have a functional or behavioral benefit, so slowing the loss of one IADL over time or reducing behavioral outbursts in more advanced dementias. Those studies are pretty mixed, so I can't say with confidence that they actually have that effect. Neither acetylcholinesterase inhibitors or memantine have shown any effect in mild cognitive impairment, and they should not be thought of as a disease-modifying drug. They are treating the symptoms of Alzheimer's disease. Memantine is approved for moderate to severe dementia, as just sort of what it was studied in. And acetylcholinesterase inhibitors are approved for mild and moderate dementia with limited efficacy in people who have already progressed to more severe stages. So that's what's out there. We've got these drugs. They work a little bit, but have a lot of problems. They've been around for a while. Clinicians have a lot of experience. They're generally affordable. And they're an option that many of us just try to shy away from. So in that really poor background of options, folks have been trying to target the pathologic underpinnings of Alzheimer's disease. And the first FDA-approved, in scare quotes, anti-amyloid therapy for Alzheimer's came out in June of 2021. This is aducanumab or Aduhelm. It received accelerated approval based on proof in the studies that aducanumab could reduce amyloid beta plaque burden on those PET scans. So that was good enough for the FDA to get accelerated approval. We've shown that there's an imaging improvement. The trials in aducanumab looked at the amyloid plaque burden and CDR-SB score. It's a clinical dementia rating scale, sum of boxes, over 18 months of therapy, dosed with an infusion every 4 weeks. This is what the CDR-SB is for future reference. It is a mixed functional and cognitive score with 0 to 3 points assigned in 6 different domains. So some of these are more objective tests of memory and orientation. Others are patient-reported independence in home and hobbies and personal care. The judgment and problem solving is sort of clinician subjectivity. So a 0 is a great score. The worst score you can get is 18, that you'd expect in more severe dementia, sort of golf rules here, you want a low score. I like a dementia rating scale that incorporates function, cognition, and sort of patient-reported outcomes, but this does make it a little messy. You're putting multiple domains into one test, so keep that in mind when you're interpreting the next couple slides. So that's the CDR-SB, not something we usually do in clinical practice. In those initial studies of aducanumab, it was the EMERGE and the ENGAGE studies that had conflicting results. So ENGAGE showed no difference in CDR-SB score. EMERGE showed a score difference of 0.53 on that 18-point scale, favoring the treatment group at 18 months, but only in the high-dose subgroup. And the estimated clinical meaningful difference in CDR-SB is like 1 to 2 points. So it didn't quite hit that. They did see a similar result in each subgroup with secondary testing. So they did an MMSE and the ADAS-Cog, which again is like a 70-point MoCA, essentially, where they saw a very, very modest difference, but only in the high-dose subgroup. With these conflicting results, the accelerated approval of aducanumab prompted CMS to clarify their coverage of anti-amyloid therapies, which are very expensive. CMS said, okay, if you've got this drug that sort of works, we don't know how well it works, it's incredibly expensive, there's no way we can afford to give it to everyone with dementia. We will cover it for people who have Medicare Part B and are enrolled in clinical trials. And if it gets full FDA approval, we will cover it if they're enrolled in Medicare Part B, diagnosed with appropriate criteria, and have a qualified physician participating in a registry with a clinical team and follow-up to care. So Medicare has created a very high barrier to receive these drugs because of the cost and uncertain benefit. That was enough that and competition to lead the company that produces aducanumab to pull it from the market about a year later. So aducanumab is no longer available, but these rules that CMS has set up for coverage of anti-amyloid therapies still exist. That has impact on the next anti-amyloid therapy down the line, lecanemab. This got accelerated approval in 2023 and full approval later that year. Similar to aducanumab, the accelerated approval was based on proof that they could get rid of amyloid plaques, with the full approval coming out after release of the Clarity AD results. This study featured about 1,800 patients who we had proven had amyloid in their CSF based on PET scan, who also had a clinical diagnosis of MCI or mild Alzheimer's disease. Folks are randomized 1-to-1, also with 18 months of follow-up. Lecanemab has one downside over aducanumab, which is that the infusions occur every 2 weeks. It's a pretty intensive treatment burden. They also use the primary endpoint of a CDR-SB score, with their secondary endpoints being reduction in plaques on amyloid PET and that 70-point ADAS-Cog score. I wanted to use the pictures from the original manuscript, but they're kind of blurry, so you're going to have to trust me here that it is very impressive what these anti-amyloid drugs can achieve in terms of removing plaque burden from the brain. So it looks like night and day. You've got a patient with tons of amyloid plaque on their PET scan, you scan them again in 6 months, it's gone. This is just one way of showing that. Don't ask me what centiloids really mean from a clinical standpoint, but lecanemab does achieve that goal of removing amyloid plaques, which is great. I think that's why the FDA felt like it was warranted to get accelerated approval. However, at 18 months, the change in the CDR-SB score between the drug group and the placebo group is similar to aducanumab. It's like half a point, which is not really considered clinically meaningful, but was statistically significant. We saw a similar result looking at the ADAS-Cog score, again, their secondary outcome, where there's a couple point difference. This graph lines up perfectly if you just put it right over the same studies that were done with donepezil or memantine. It is hard for me to say that lecanemab achieves any better clinical outcomes than the drugs we already have that we're already not using a lot of. That hasn't stopped people. So there is a third option if you are excited by these graphs. Donanemab is the newest on the block. This was approved in June of 2024. Very similar study design to aducanumab and lecanemab. 72 weeks of follow-up, 1,800 patients. This one's every 4-week infusion. With one important caveat that in the Trailblazer study, if someone achieved sort of PET remission of amyloid at the 24-week or the 52-week mark, they were switched to placebo. This is to limit the amount of drug exposure and see if they could achieve the same outcomes with shorter treatment durations. So these patients got a lot less monoclonal antibody than the other trials. But still, we see pretty similar results. So this is the integrated Alzheimer's disease rating scale. Similar to the CDR-SB, it's sort of a hodgepodge of functional and cognitive outcomes where we see less than clinically important difference. At 76 weeks, they saw about a 3-point difference between the drug and placebo group. MCID is considered to be around 5 for the IADRS. The donanemab trial also had CDR-SB as a secondary outcome, and just like its brethren, we saw like a couple point or less than half a point difference between the drug and placebo group at 76 weeks. If I sound unexcited, it is because, like I said, these are not that much better than the drugs we already have, at least in the couple trials we've got. These are every 2 to 4 week infusions, so high treatment burden, that are very expensive. And if that wasn't enough, across all of these monoclonal antibody trials, patients experience something called amyloid, that we've now dubbed the very beautiful name of ARIA, or amyloid-related imaging abnormalities. Again, across all 3 of these drugs, we saw edema in the brain occurring in about 30% of patients, microhemorrhages occurring in about 20% of patients, For what it's worth, only about a quarter of the patients that had imaging abnormalities reported symptoms, including headaches, dizziness, nausea, and confusion. Um, I think most of us agree that we don't want to see edema or microhemorrhage, regardless of how symptomatic it is. So this is a huge potential barrier to treatment. Um, the discovery of these amyloid-related imaging abnormalities has also led to the recommendation that patients getting these drugs are getting serial MRIs throughout their treatment course to look for these imaging abnormalities. So that's just another layer of treatment burden for someone who wants to go get lecanemab or donanemab. Adding on to that, patients with an APOE epsilon 4 allele, that is one of our most common Alzheimer's disease risk genes that runs in families with early onset Alzheimer's, they were at a much higher risk for these imaging abnormalities. So that is also considered part of the pre-screening for this treatment, is that you do the genetic screening. It's going to require a visit with a genetic counselor, which may or may not be covered by your insurance. Kind of the list goes on. Again, I'm sounding very negative. One thing I don't know about these drugs, and no one knows, if we have successfully eliminated amyloid plaque in the brain, do these patients do better 5 years down the road? That might be true. We just haven't followed them that long. So I could be changing my tune entirely if you ask again in a few years about whether these drugs are helpful. But up front, there is a lot of treatment burden with not a lot of great clinical outcomes in the first 18 months to 2 years. But I don't want to be totally hopeless. There's a lot in the pipeline for Alzheimer's treatment. This is 2024 on clinicaltrials.gov. There are 164 trials open, assessing 127 drugs ranging from disease-modifying therapy, small molecule therapy, cognitive enhancers, many in phase 3 already. So again, I was joking before this talk, don't agree to give an updates talk in a field that's changing a lot because you have to keep updating it every time you give the talk again. I'll probably have to update this if I give this talk again in 6 months, and I'm glad because I want there to be more treatment options for our patients. I want to put a plug in. If you have patients with Alzheimer's disease or MCI, we need more than 36,000 patients to populate just the currently registered phase 3 trials. So there's a huge need for Alzheimer's disease research. We typically, historically, do not involve older adults in research enough. They're really underrepresented across all trials. There are a lot open here at the University of Colorado. If you want to check out the neurology department's research website, we have over 40 dementia-related trials just last year, including one clinical trial. And one thing that I do very much love about our neurology colleagues, they have a good research infrastructure, and they do have navigators available who can guide participants to any qualifying studies. They've got a lot more going on than just Alzheimer's research, but I want to put in a plug for Alzheimer's research specifically. Again, in the theme of not expressing hopelessness, there is a lot that we can do that is more effective than the drugs that we have for helping people improve quality of life and function in dementia. So what I'm usually focusing on in the geriatrics clinic are many non-pharmacologic approaches to dementia. And the kind of pillars that I will have people focus on are physical activity, socialization, and diet. Not because any of those are going to slam dunk, prevent progression, or slow down or stop your memory loss. But those are all things that have multiple positive impacts on other aspects of quality of life and health that patients can feel in control about when they have gotten a diagnosis that is easy to feel out of control. Especially the physical fitness and exercise. There are mixed, but many mixed studies suggesting slowing of cognitive impairment, and that's going to slow down the loss of functional impairment in most older adults, but especially in those with dementia. Early diagnosis of dementia, so why I want us to stay on top of our workup, is going to be especially important for long-term health and financial planning. So the earlier you can identify that someone has dementia, the better you can prognosticate what type of dementia they have, the easier it's going to be for them to figure out what they want to happen to their assets as their disease progresses. The easier it is for them to plan for long-term care, which they might need down the road. The easier it is for them to start learning psychological coping skills or participate in counseling, which they might not be able to participate in later in their disease course. So keep in mind that there's a lot we can be doing other than drugs to keep our patients as healthy as we can. One of those that I really like to plug is complex care management. I set this up in contrast to our monoclonal antibody therapies. Um, this table shows modeling of costs, so it's a modeling study, for 4 dementia care coordination programs, uh, all of which have an intervention cost less than a single dose of our monoclonal antibodies, all of which lead to a positive incremental benefit in quality adjusted life years, all of which were found to be ultimately cost saving, most likely driven by their ability to reduce days in long-term care, even if only by a few weeks. Care management has a much greater cost efficacy than the monoclonal antibody therapies. These are just a few out there. None of these are available here. There is one that is relatively new that I want you guys to know about. That is our GUIDE model. This was put into place under the Biden administration and is still active under CMS, unlike some of our other patient support programs. GUIDE stands for Guiding an Improved Dementia Experience. This is a reimbursable activity for dementia care coordination, especially the actions of a dementia care navigator. A lot has to happen to qualify for reimbursement from Medicare under the GUIDE model. Patients have to have a comprehensive dementia assessment, a written dementia care plan, 24/7 access for dementia concerns, which we at the seniors clinic sort of take on as your 24/7 access point. Regular monitoring and support, as well as coordination with primary care on support services, medication management, and caregiver education and support. We are one of 6 groups, 3 of which are active, who are participating in a GUIDE model. Now it is based out of our seniors clinic. Shout out to Dr. Lum, Adrian Tatro, and the rest of the group, who will do monthly or bi-monthly calls with caregivers to educate them on dementia care needs. It has been a lifesaver for some of my patients. I have folks telling me that they were on the verge of tears until they finally got calls with Adrian. I had patients say they are certain their mother would be in a nursing home if it weren't for a call from Jessica. Some of the things they will do is highlight medication problems that come up before, like ahead of the next visit. They will introduce things like a MOST form or financial power of attorney that we can then discuss in the next visit. So this has been a really great program. It is open to anyone in the UC Health system as long as they're primary care physicians here. It is limited, however, to traditional Medicare. But any of your patients with dementia with traditional Medicare, I highly recommend referral to the GUIDE program. They are open for business. There's a little bit of a wait, but they are ramping up. And at least so far, CMS has not cut off support for this program. So check it out. If you have someone who does not have traditional Medicare or is outside our system but needs more help, there is a lot out there that has not gone away. With the recent dissolution of the Association for Community Living, many dementia support programs, including meal delivery and transportation, are struggling. I haven't had a chance to update these slides because that was just last week. But by congressional mandate, every county in the US still has an area agency on aging. So everyone, no matter how rural your patients are, has a contact point for aging support services. In the Denver area, that's DRCOG, or Denver Regional Council of Governments. The QR code here is just the AAA directory for the state. We also still have access through the state for the Aging and Disability Resource Center. That's a hotline you can call to help connect people to in-home services. And then if you are looking primarily for educational materials, I usually recommend the Alzheimer's Association. They have been leaning more heavily into monoclonal antibody therapies than I would like, but that doesn't change the fact they still have some really good patient education on their website. Other places you can send patients for dementia care within our system if you are still just sort of not sure where to go. The geriatrics clinic is a great option. We have multiple neurologists who specialize in dementia care alone. And then our neuropsych testing, don't forget, is available through our neurosurgery department. So in summary, our dementia diagnosis remains rooted in the history and exam, even as we develop new serum biomarkers, new advanced neuroimaging, CSF testing, et cetera. While there are exciting advances in drug development for Alzheimer's disease, we really haven't substantially moved the needle on prevention or treatment yet, but there is a lot in the pipeline. And do not forget that the efficacy of non-pharmacologic interventions so far continues to outpace medications. There's still a lot we can do for our patients, even if the current state of drug development seems a little hopeless or pessimistic at times. All right. That wraps things up with plenty of time for questions.
We have a whole slew of questions in the chat that we'll
Cool.
get to, but it looks like, John, do you have one here in person?
Yeah, thank you. That's a great talk. Multi-part question. Acknowledging the limitations of anticholinesterase inhibitors, memantine, do they have any benefit in vascular dementia? And if no, do you recommend any evaluation, or you just kind of see how they do and go from there?
Good question. The majority of the positive trials in acetylcholinesterase and memantine are in Alzheimer's disease. There are studies in vascular disease that suggest a benefit. They're just less studies with slightly more mixed results. So it is, I would still recommend trial. Like vascular dementia is still a state where they might have benefit and you can still try them. The only other dementia diagnosis with good evidence for acetylcholinesterase inhibitors is any of our Parkinsonian dementias. So Parkinson's disease or Lewy body dementia, they might actually be more helpful. Acetylcholinesterase inhibitors are not helpful in FTD, not helpful in Huntington's, not helpful in HIV-associated dementia. So they're not perfect for everyone. But since most patients are going to have vascular disease, Alzheimer's disease, or mixed dementia, you can try it in kind of most of your typical cases.
That ties nicely into the theme of acetylcholinesterase inhibitor and memantine questions. Ryan was asking for patients who've been on those meds for a while, when do you recommend discontinuation?
Good question. I will revisit if therapy, if the family or caregivers feel like therapy is helping, I'll sort of revisit that every 6 months to a year. Usually there becomes a point in the dementia course where they just want their loved one or the patient just wants to be on less pills. And that's often when I'll start to pull it back. Again, there's less evidence for the acetylcholinesterase inhibitors in severe dementia. So as someone becomes more functionally dependent, that's often when I'll revisit the conversation of whether these drugs are helping. There's limited evidence that any of these drugs help in patients in long-term care. So that's often where these drugs get peeled back. You will still find patients and family members who feel like, oh my gosh, that drug is a lifesaver, and we tried to stop it one time and things got so much worse. If they seem to be tolerating it, just keep it going. There is some thought that even in advanced dementias, acetylcholinesterase inhibitors may help modulate behaviors. So you just need to constantly make sure that the drug is actually doing something and not causing any of those side effects that we talked about.
He says that it seems like neurologists are often starting one of those two medications, and wondering why you think neurologists prescribe them so much.
They get a consult and feel the need to do something. This is actually one of my favorite little studies. I can't never find it again because it's a poster. If you look at prescribing rates of acetylcholinesterase inhibitors, neurologists prescribe a ton, psychiatrists prescribe some, and then geriatricians prescribe very little. There's a huge difference between specialties, which would give you an idea of how effective the drug is, because there really shouldn't be variability. There's also a ton of regional variability in how often these drugs are prescribed, which again suggests there's probably something up with the efficacy of the drug if there's that much variation in practice.
Yeah, so my question relates to sort of patient preference. So, I probably see a younger population than you do, maybe not by a lot, but the majority of my patients, even sometimes with very sort of minimal documentable symptoms, want a referral to neurology. They want neuropsych testing, and they often want to start drugs. Just like it's like they're so freaked out about the possibility, and so I'm just curious, what any sort of tips you've got on managing those expectations, or on successfully convincing people that maybe those are not in their best interests.
Good question. I don't fight that much if someone wants greater clarity or a second opinion because of how distressing this diagnosis can be. As a geriatrician, I do tell them that you're going to need a home base. Your primary care is your home base. no matter what happens, I'm going to be the one helping you out with a lot of these drugs and signing you up for programs and getting you to specialists, et cetera. So like, I'm happy to send you for a second opinion. And I just try to frame it that way so that a neurologist doesn't then take over their care and I never see them again. With like neuropsych testing, if there is a lot of distress, neuropsych testing might be helpful because they can learn their weaknesses and strengths, and the psychologist will actually go through the results with them. So again, it's partially therapeutic. So I'm not going to fight that hard if a patient really wants to. It's the drugs where I'll push back a little bit. Usually patients are pretty receptive. If I don't think they would benefit much at all from an acetylcholinesterase inhibitor, patients are usually really receptive to like, this is another pill you're gonna have to take every single day that has potential side effects. Maybe we don't try it, or maybe we revisit this next time, or maybe we do it on a short-term basis and see how it goes. That's the one where I'll sort of push back a little bit more. But I do think that in dementia, it is always pretty reasonable to be a bit more aggressive with your workup and diagnosis. We all hold geriatrics grand rounds on this, and I missed it. I wish I had been there for answering this question. My understanding is that the data suggesting that hearing loss precipitates dementia is a little poor. It is mostly just a very strong association between sensory loss and dementia. So whether there's a pathologic underpinning of hearing loss leading to dementia is, I frame it as uncertain. I could probably do a little more reading on that topic. But I tell patients, like, that doesn't matter. You can't hear me. You can't hear the people around you. That's going to prevent you from socializing. That's going to lead you to increased risk of falls. That's going to impair quality of life. So I really try to push people to get their hearing fixed, but I don't typically frame it as a dementia prevention exercise.
Listen, ask, what are your thoughts on prevention? For example, I heard some promising information about the Shingrix vaccine. What are your thoughts on that?
Good question. Specifically in the Shingrix vaccine, I think everyone should have it to prevent shingles anyway. The data on Shingrix being preventative for dementia is a little fuzzy because, again, it's mostly association studies and hard to tease out. But there was a newer trial with a good natural control out of the UK that's worth Googling and looking into. Otherwise, I'm not doing a lot different from prevention than we're doing in most internal medicine clinics. Like, I'm trying to keep blood pressure down. I'm trying to get people to exercise, control diabetes, et cetera. I think the one task that maybe we do a little bit more of in geriatrics is really emphasizing the exercise bit. My line with patients is that I care a bit less about what you're eating and whether you have a glass of wine and whether you have a cigar in your 80s. I just need you to move your body, because that is going to more effectively head off functional decline.
Annie is wondering, any advice for clinics? We see many of these patients calling and messaging with the same questions over and over, as they don't remember when they previously called or messaged, and they don't remember the answers either.
This is where those dementia care coordination programs like the GUIDE program are especially helpful, because it's going to take repeated teachings, exploration of alternative communication methods, and familiar voices to keep reiterating to patients and their caregivers how to triage these problems that keep coming up over and over again. So if you can coach a caregiver on which problems need to be acknowledged and which ones can be ignored, on how to defer concerns that come up over and over again, on how to deal with anxiety, that's really where the money's at. Like, if you are struggling with a patient who cannot coordinate their own care, what they need is greater care management, so that they have a person they can go to who knows them and knows their situation.
Anxiety, and so I have a couple of patients similar to the one you described, better cognitive scores, who go through neuropsych testing and actually perform quite well. and yet their problem seems to be they've performed really well their whole lives, and just the decrement in what they perceive as their ability now versus to what they consider acceptable, that delta, it almost seems like there's sort of this performance anxiety that drives it. I'm just curious, any tips for, I mean, one, do you see that? And two, any tips for managing that?
I see that a lot. I've got a patient who used to be a memory trainer, and has like the world's mildest cognitive impairment, but he notices it and he is anxious. Um, you don't forget that all the same interventions for generalized anxiety or adjustment disorder still hold. So these are patients where I will sometimes try an SSRI or mirtazapine. In earlier disease states, you can still rely on therapy and counseling as well to help reinforce the positive skills that they do have, even as they're perceiving a change in their cognition. So do rely on your psychologist. It gets a lot harder in more advanced disease states where people don't remember the counseling they've received, and that's where you really just have to engage caregivers in being that reassuring presence. None, unfortunately, if we do have to rely on anxiolytics, none of our psych meds have any particular disease modifying effect for dementias, but they're all still usable and valid. Like we can still try to control anxiety that way.
One more question, and then we'll transition to a closing statement from you, Dr. Walker. Lisa's asking, are there any shared decision-making tools for acetylcholinesterase inhibitors and memantine?
Yes, that's my short answer. I don't use any of them, but they're out there. Yeah, I don't have a good answer. Usually if I'm having the conversation in the middle of a visit, I don't have time to pull up a shared decision-making tool and go through it with someone, but people have tried to create them. Don't want to end on a dud question, but sorry, I don't know the answer to that very well.
That's fine. This has really been wonderful. So any summary closing thoughts you'd like to offer us?
I will just reiterate some of the things on the summary slide. So even though dementia can be a tough diagnosis for us and for patients to deal with, it is important that we make the diagnosis so we can better prognosticate. And the clearer we can be on diagnosis, the more we can utilize advanced therapies as more come down the pipeline, which I anticipate will be a big change in our careers in the next 10 years. So there's hope out there. And do not forget that some of the things that have the biggest impact on quality of life are still the non-pharmacologic options.
Informative, both the comparison of the infusion therapies and their efficacy compared to some of those oral therapies, the non-pharmacologic treatments, as well as some of the information at the beginning about diagnostics. So thank you so much for joining us today.
Thanks, everybody.